Dear students, today we will discuss about two very important clinical topics about bronchial asthma and chronic obstructive pulmonary disease. First of all, I would like to apologize for some technical problems because if I switch on slideshow, our presentation shown only first slide. That's why I should switch and make slide presentation manually. So we will start with current definition. First of all, I would like to emphasize that international guidelines concerning diagnostic and treatment of bronchial asthma is called GINA guidelines, Global Initiatives for Bronchial Asthma. According to GINA guidelines, asthma is heterogeneous disease. What does it mean, heterogeneous disease? It means there are a lot of asthma with different mechanism of pathogenesis, different trigger and etiology factor. That's why it means heterogeneous disease. Asthma have got a difference endotype, and asthma have got a difference, a lot of clinical phenotype. In the central of definition of bronchial asthma, you can find the asthma usually characterized by chronic airway inflammation. That's crucial. Our understanding that asthma is chronic airway inflammation changes our understanding of this disease and lead to improved prognosis, improving treatment, prophylaxis, bronchial asthma, and frankly speaking, well-controlled bronchial asthma, it's help person to avoid complication and maybe become Olympic champions. Other things, asthma with high risk and uncontrolled asthma lead to asthma mortality from asthma. You can ask me, in case of chronic bronchitis, also present chronic inflammation, what difference between chronic inflammation in case of bronchial asthma comparing with chronic bronchitis? Chronic airway inflammation in case of bronchial asthma lead to variable expiratory airflow limitation with clinically manifest the respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity. Asthma remains very important worldwide medical problems because affecting over 260 million people globally. And people with asthma often have period of worsening symptoms, a worsening of airway obstruction called exacerbation. This exacerbation may be life-threatening exacerbation, lead to death patient during this severe and fatal bronchial asthma exacerbation. Most of the comorbidity, morbidity and mortality associated with asthma is preventable, particularly with use of inhaled corticosteroids. In this slide, you can see asthma prevalence and mortality and morbidity. In the right side of this slide, you can see the case of fatality. And the left part of this slide, you can see proportion of population with asthma. You can check that in a country where better diagnostic, it's lead to increase prevalence of bronchial asthma. But in this country, very lower the level of mortality from the bronchial asthma. Other things in country, for example, Russia Federation, Denmark, Greece, where prevalence of bronchial asthma no more than 4-5%. The case of fatality rate highest. That's why conclusion, better diagnostic, better treatment, better prognosis. Definition of COPD you can find also in other international guidelines. It's also global initiatives for obstructive lung disease. It's called GOLD, updated annually based on the results of clinical investigation, based on the evidence medicine. According to GOLD guidelines, COPD is a common preventable and treatable disease, is characterized by persistent respiratory symptoms and airflow limitation. That's why it's very important characteristic of COPD, persistent airflow limitation. Previously in GOLD 2016, in this definition, you could find the definition about chronic airflow inflammation. And by the way, in clinical recommendation of Russia Respiratory Society, you also can find the definition about chronic inflammation. But in the international guidelines, now, as you see at the slide, you can't find this definition of chronic inflammation. It's not means that chronic inflammation absent, it's present, but persistent airflow limitation happened due to airway or alveolar abnormalities. What kind of abnormalities, we will say about it later. But this airway or alveolar abnormalities usually caused by significant exposure, noxious particles or gases. First of all, it's smoking. And what medical problems COPD? In this painting by Vasily Vasnetsov, you can see this painting is called Warriors of the Apocalypse. The third warriors is COPD, which kill population. And COPD is currently the third leading cause of the death in the world. More than 3 million people died from the cold, the COPD. But in the 2019, and globally, the COPD burden is projected to increase in coming decades because of continued exposure of COPD risk factor and aging of the population. Historically, you should know there are two hypotheses concerning bronchial asthma and COPD. First hypothesis belonged to Dick Lee, professor from Netherlands. Dick Lee considers that COPD and asthma is a different manifestation of a single disease, a chronic non-specific pulmonary disease. But now we and medical society belong to the hypothesis of formulated by Professor Charles Fletcher from Great Britain. COPD and asthma are different diseases that are characterized different mechanism of pathogenesis, the difference in information, difference however remodeling and varying epidemiology as to. In this slide, you can see the inflammatory cascade in asthma and COPD. You can see that main etiology factor and trigger is allergen in case of bronchial asthma. In case of COPD, it's noxious particles or gases, and mostly it's cigarette smoking. And this trigger factor lead to, in case of bronchial asthma, lead to hyperactivity of, firstly, it's T a helper type 2, which switch immunoglobulin production into the plasma cells, which produce IgE antibody against this allergen. And it's start of allergic inflammation, and main cells which formate this inflammation in case of bronchial asthma, it's eosinophils, mast cells. But now you should know that not only T helper type 2 play an active role in this inflammation. Also, cells which belong to innate immunity, namely immature lymphoid cells type 2, also produce the same cytokines, including interleukins 4, 5, 13, which switch immune response toward the allergic response, and then finally this information lead to variable airflow limitation. In case of COPD, other type of cells play an active role in this information. It's cytotoxic cells, CD8 plus, which and responsible for formation of this information. And main cells, it's neutrophils, which play an active role in this information. Alveolar macrophage also play active roles in COPD information, and these cells produce pro-inflammatory cytokines, including tumor necrosis factor alpha, interleukins 8, interleukins 1b, interleukins 6. It's cytokines and cells finally lead to formation of persistent airflow limitation. You should know that according to pathogenesis, now asthma can be divided in at least two categories. T2 asthma, it's asthma which inflammatory process formed under the influence of hyperactivity of T2 type cells, including T helper type 2, innate immunity, image lymphocytes type 2, image lymphoid cells type 2, dendritic cells. And T2 inflammation can be divided into two subgroups. It's high T2, it's prevalence allergic and eosinophil inflammation, and lower T2, which the role of neutrophils in this inflammation increase, but not higher like in patient with non-T2. Non-T2 is mostly neutrophilic inflammatory response due to activation of T helper type 17. It's classified as a non-T2 asthma. So in this slide, you can see the pathology of COPD and asthma. In the case of both the COPD and bronchial asthma, the present inflammation. But smooth muscle hypertrophy, it's more typically for patients with bronchial asthma. And but it's not concerning only hypertrophy of this smooth muscle layer. It's concerning to bronchial wall remodeling when you can detect smooth muscle cells in to the subnuchal layer. That's why generally the amount of smooth muscles significantly increase, and these smooth muscles provide hyper responsibility of bronchi for specific or unspecific stimulus. And in enlarged of basal membrane also typically for patient with bronchial asthma, and also brain role in bronchial walls remodeling. But concerning fibrosis, especially sub and peribronchial fibrosis, more typically for patients with COPD. Peribronchial fibrosis, it's like a ring which provide persistent airflow limitation. It's like a ring which provide limitation of dilation of bronchi under the influence some kinds of bronchodilators. That's why peribronchial fibrosis, it's one component of which provide persistent airflow limitation. It's one component of airway abnormalities. We talked about it when we discussed about definition of COPD. Other abnormalities concerning parenchyma, because COPD, it's not only problems with bronchi. If it's COPD will be problems with bronchi, it's called chronic obstructive bronchitis. But now this term is excluded from 10th edition international classification disease, because in COPD, problems with airways, bronchis. Secondly, it's problems with parenchyma. Gap alveolar and formation of emphysema is second component. Abnormalities of lung parenchyma, which provide the presence of persistent airflow limitation, because excessive air in the lung during exhalation compress this mainly small size of bronchi and lead to persistent airflow limitation in case of COPD. In this slide, you can see that in case of asthma, it's smooth muscle hypertrophy, and in submucous layer, the presence of smooth muscles cells. In case of COPD, you can see peribronchial fibrosis like a ring surrounding the bronchial walls, and formation of emphysema. And in both asthma and COPD, typically mucus hypersecretion and changes the quality of the mucus secretion. It's high viscosity, which provides a touch mucus plug into the bronchial walls. In case of COPD, you can see increase of macrophages, CD8 lymphocytes, and metaplasia of epithelials, hyperplasia of goblet cells, and mucous gland hyperplasia, and no basal membrane thickening, and practically little increase in airway smooth muscles layer. First of all, clinically, if you will meet with patient with bronchial obstruction, first question you put answer, is it chronic process or acute process? And both asthma and COPD is a chronic airway disease. That's why history of chronic of recurrent cough, sputum production, dyspnea, wheezing, repeated acute lower respiratory tract infection is support the presence of chronic airways disease. By the way, in our understanding of COPD at the presence of chronic bronchitis plus emphysema. The definition of chronic bronchitis is chronic cough more than 3 months during consecutive 2 years. That's why it's explained and give you key for diagnosis of chronic character of airways disease. And report of previous diagnosis of asthma and COPD. You should ask patient about previous treatment with inhaled medication and respond to this medication. Obviously, you should ask about smoking, tobacco smoking, and exposure to environmental hazard, occupational, domestic exposure of airborne pollutants. For diagnostic, you should pay great attention to age of onset. Asthma usually childhood onset, but can onset in any age. You should know such clinical phenotype with late asthma, but most of case of asthma start onset in childhood. And COPD is diagnosed more typically after 40 years of old. Also, you should recognize pattern of respiratory symptoms. And we talked about bronchial asthma is a variable airflow limitation. That's why variation in symptoms over minutes, hours, or days. For example, at morning, patient was like a healthy, but then he can perform physical exertion, can run, but after contact with allergen, it's lead life-threatening exacerbation in 2 or 3 hours. Patient required to hospitalization and hospital admission in the intensive care unit. That's why variation in symptoms over minutes, hours, or days. In the case of COPD symptoms, the main symptom, by the way, it's cough and dyspnea. This symptom persistent despite treatment. So each day, this symptom present. In case of bronchial asthma, symptoms worse during the night or early morning. But patient with COPD mostly complains for good and bad days, but always daily symptoms and exertional dyspnea present. Patient with asthma symptoms triggered by exercise and emotional stress, including laughter, dust of exposure to allergens. In case of COPD, chronic cough and sputum precede onset of dyspnea unrelated to trigger. So lung function. But in case of COPD, monitoring for the lung function revealed record of variable airflow limitation. For example, if you make peak flowmetry at night and morning, it may be difference in peak expiratory flow, more than 10%. And patient with COPD, persistent airflow limitation, and in all spirography investigation, you can detect and revealed post-bronchodilators ratio forced expiratory volume for 1 second, forced vital capacity less than 0.7. In each investigation, you obviously should find this main spirography criteria of COPD. Without this criteria, we can't to make diagnosis COPD. Lung function between symptoms in case of asthma, normal. In the case of COPD, persistent airflow limitation. According to past history of family history, in case of COPD, previous diagnosis of asthma, family history of asthma and other allergic disease. In case of COPD, mostly previous diagnosis of COPD, chronic bronchitis, emphysema, and heavy exposure to risk factor, tobacco smoking, biomass fluid. You should obviously evaluate the intensity of tobacco smoking. It's so-called PAC index or cigarette index. For example, if patients smoking 1 pack daily during 15 years, the tobacco smoking history 15 pack years. More than 10 pack years, it's dangerous for development of COPD. That's why if patient smoking 5 years, smoking during 5 years, but each day smoke 5 packs, it's 10 pack period. That's why it's in 5 years, patient have risk for development of COPD. Time course, in case of asthma, no worsening of symptoms over time. Symptoms vary seasonally from year to year, may improve spontaneously or have an immediate response to bronchodilators or to inhaler corticosteroids over weeks. In case of COPD, symptoms slowly worsening over time. progressive course over a year, and rapid-acting bronchodilators treatment provides only limited relief. Chest spray usually known in case of asthma, but severe hyperinflation is the signs of emphysema in patient with COPD. But patient with asthma and COPD should undergo complete clinical and lab investigation, including chest X-ray, because this complete clinical investigation help you to make differential diagnosis. For example, often tobacco smoking is a risk factor for lung cancer, and in some cases, clinically, maybe by spirometry, it's typically COPD. But if patient perform X-ray examination, chest X-ray, and lung tumor can be detected, and main diagnosis in this case, it will be lung tumor. But question concerning bronchial asthma, recurrent episode of wheezing. By the way, the rule of asthma, if you detect wheezing, the first diagnosis is asthma. If asthma after investigation was excluded, in only one way to exclude asthma in case of wheezing, after complete clinical investigation. Troublesome cough at night, especially in childhood, in adolescents and children. Cough or wheeze after exercise. It present exercise-induced asthma. Cough, wheeze, or chest tightness after exposure to airborne allergen or pollutants. Could go to the chest or take more than 10 days to clear. Pay attention to history of pattern of symptoms. Perform physical examination, measure of lung function, measure of allergic status to identify risk factor. But when you make physical examination, you can, during auscultation, you can check in case of bronchial obstruction, changes the ratio between expire or and to inspire. For example, in a normal case, it's the time of expire ratio to inspire. It's approximately 1:1. In case of bronchial obstruction, you can see that inspire and prolonged expire, the ratio 1:2. And during prolonged expire, you can detect wheezing, dry rails, and very important to make during auscultation, make forced expiration. Due to forced expiration, when we ask patient to blow through the open mouth, expire to the open mouth. Also, you can these symptoms significantly increase and revealed during forced expiration. Why forced expiration? And often bronchial obstruction connected with expire, because it's explain the physiological changes in the cross-section on bronchi due to expire. When we inhale, our cross-section of bronchi significantly diminish. If patient have got obstruction, which provided by the presence of bronchospasm, smooth muscles, construction, edema of the mucous layer, and mucus plug attached to the bronchial with narrowing of the bronchial walls. When we inhale, our diameter of the bronchi enlarged, and air more easy to pass into the lung. But when patient make as higher, mostly forces higher, our diameter of the bronchus, which narrowing by the bronchospasm, edema, and mucus plus, this maneuver more difficult for patient, and it take more time, and you can detect physiological changes, pathological changes during auscultation. All patients should, with bronchial obstruction, when we detect bronchial obstruction, should direct it to spirometry investigation, and you should firstly check ratio between FEV1, FEC. But I would like to stress that all spirometry investigation should perform with tests with bronchodilators. It's a very important since make before bronchodilators. It's mostly short-acting beta agonists, salbutamol, for example, 400 microgram, and after inhalation of salbutamol, patient should make a retest, and ratio between FEV1 FEC after salbutamol inhalation. If this ratio less than 0.7, it means the spirography criteria of COPD. But because if other things, for example, if before salbutamol test, this ratio meet with criteria, after salbutamol, this ratio more than 0.7. That's why we can't write to make diagnosis of COPD. Okay, but these tests help you to detect so-called reversibility of airway limitation, bronchial obstruction. So we should check the changes in forced expiratory volume for 1 second before and after inhalation of salbutamol. If we detect increase FEV1 more than 12% and more than 200 milliliter, it's positive reversibility test. If less 20% and less 200 milliliter, it's negative reversibility test. By the way, I would like to stress that now GINA and GOLD guidelines strictly not recommended make differential diagnosis between asthma and COPD only for this reversibility test, because, for example, in patients have got a uncontrolled inflammation and airway, in patient with asthma have got a uncontrolled inflammation and have sometimes have got a very limited response for inhaled bronchodilators. It's not bronchial asthma, but patients in this case have got negative reversibility test. Other things, 1/3 patient with COPD have positive reversibility test. That's why it's you should summarize all clinical and symptoms and signs, history of disease, and the clinical and lab investigation. That's why you make right to make diagnosis, COPD or bronchial asthma. Sometimes it's needed to monitoring, for example, significant improved of bronchial obstruction. It's if a patient with COPD, you should change diagnosis for bronchial asthma, for example. Okay, in this test, you can see in case of asthma, before bronchodilators, before salbutamol, diminish of forced expiratory volume, and after salbutamol, significantly improved, more than 12%. And patient with exercise-induced asthma should be undergo exercise spirometry. Patient with asthma who have no any clinical signs, and mostly it's a remission of asthma, and for expertise purposes may direct it to methacholine or histamine challenge test. And, this test performed in special department when have got a specialist with experience for this test, and it's mostly this test performed in patient condition, and patient with bronchial obstruction and patient who have got a hyperresponsiveness of bronchi. If a patient contact with methacholine or histamine, low dosage of methacholine or histamine lead to bronchial constriction, airflow limitation, which confirmed by spirography investigation. That's why it's because methacholine is cholinergic agonist, which lead to bronchospasm. That's why it's so-called broncho provocation test. Peak expiratory flow, very important method for self-monitoring patient, and this very cheapest equipment for self-monitoring and patient from that morning and night, and sometimes during exacerbation, blow, exhale to the devices, and this nomogram, a normal range, which dependent from sex, woman, man, height, and age of patient. For example, 25 years woman who have a height 175 centimeter, approximately the best peak expiratory flow 440 liter minutes. That's why the green zone we established for this peak flow meter, and that's why 250 milliliters, it's 100% to 80%, it's green zone. From 80 to 60, it's yellow zone, and red zone less than 60%. If patient during self-monitoring have results in green zone, it means everything okay and no problems with airflow limitation. If patient have got results in yellow zone, it means partial control for inflammation and need to add some control medication for improving control for firstly for the for inflammation. And the red zone patient should contact with physician as soon as possible because very significant diminish of peak expiratory flow. But if patient measure peak expiratory flow at night, at morning, it's help you to compare these results. And for asthma, typically the presence of peak expiratory flow variability more than 20%. It's between the results at morning and night. As a test, mostly it's use this test in special department. So diffusion of the gases normal in case of asthma, in case of COPD, often reduced. Like arterial blast gases, normal between exacerbation in case of asthma, but drop only in case of severe bronchial asthma exacerbation, and maybe diminish due to development or chronic lung failure in case of COPD. Airway hyperresponsiveness we told, but it's if we detect airway hyperresponsiveness, it's favor asthma, but not useful for its own in distinguishing asthma from COPD. Higher resolution CT scan. I told that more typically for COPD the signs of emphysema, air trapping, emphysematosis changes. In case of asthma, usually normal, but it may be increased bronchial walls thickening. So what allergy test, skin test, a detection of specific IgA, it more typically for bronchial asthma, but not essential for diagnosis. The increased concentration in exhala nitrogen oxide. It's more typically for eosinophilic inflammation. In case of COPD, usually normal but low in current smoker. A blood eosinophilia support asthma diagnosis and may present during exacerbation of COPD. By the way, from the previous course, you should know that blood eosinophilia often the blood eosinophilia and the eosinophilia in case of bronchial asthma present not only the blood circulation but also locally in the sputum, in bronchial alveolar lavage. In case of asthma, often increased eosinophils in sputum and destroy eosinophils, it's so-called Charcot-Leyden crystals, and Cushman spirals also often present in case of asthma. Sputum inflammatory cells analysis, but its role in differential diagnosis is not established in large population. But it's useful for diagnostic asthma and COPD because we told in case of asthma, it's more eosinophilic inflammation. In case of COPD, its main cells are neutrophils. Okay, that's why after complete investigation, including clinical lab instrumental investigation, we make a conclusion about what is it, asthma or COPD. That's why first place we should diagnose bronchial asthma or COPD. Then second place in diagnosis, it's severe, it's a grade of severity. And how can we evaluate asthma severity? Firstly, it's at the during first contact with patient, its initial diagnostic of severity. It's based on the symptoms of asthma. For example, if patient have got daily symptoms, it's moderate persistent. If patient have got, for example, 6 symptoms 6 times per week, it's mild persistent. If patient have got, for example, 1 time a week, maybe asymptomatic is mostly intermittent. There are 1 intermittent and 3 persistent, mild, moderate, and severe. Severe, it's continuous symptoms. Limitation of physical activity, treatment and daily nighttime symptoms. That's very important things that I would like to repeat once more. This evaluation of severity for the initial visit, first visit. It's patient not treated by control medication. It's according asthma symptoms. If we prescribe therapy and patient should treat it according steps, you can see step 1, 2, 3, 4, but there are 5 steps. We'll say about it later. The second and next visit, assessment of severity according to the grade of steps, according steps therapy. But how can we evaluate symptoms for this after first visit, second and next visit? The symptoms help you to evaluate the level of control, because the main goal of treatment of bronchial asthma is reach well-controlled bronchial asthma. That's why we evaluate symptoms and make conclusion to the control. For example, if patient treated according to step 1 or step 2, it's during second or third, fourth visit and other, it's a mild asthma. Third step, patient treated by third steps, it's moderate. Fourth and fifth step at severe asthma. But now, Gina, no plan to change the assessment of severity, but it will be future. But now you should make assessment of severity according to these steps. So the 2 main types of pharmacological treatment used in asthma and can be divided into 2 categories. Reliever, this medication direct to the symptoms, and control medication. It's mostly treated chronic airways inflammation in case of asthma. Stepwise approach to control asthma symptoms and reduce risk. In this slide, you can see the treatment approach in case of bronchial asthma. It's according Gina 2021. According these global initiatives, now we have two approaches to treatment of bronchial asthma. But this last recommendation for treatment in bronchial asthma and preferable way, it's you can see the combination step 1 and step 2. In this combination, you can prescribe such patient in one device, inhaled corticosteroids plus formoterol. Formoterol, it's a long-acting beta agonist, which very quickly onset of action. Formoterol in 1 or 5 minutes, it's onset of action of formoterol for bronchodilators. That's why this long-acting beta agonist can use for reliever medication. And in combination with inhaled corticosteroids, these drugs during step 1 or step 2 can be used as a controller and reliever medication, for example. And patient with mild asthma can use this combination inhaled corticosteroids plus formoterol only during bronchial asthma exacerbation or symptoms. It's in case of mild asthma. In case of step 3, moderate asthma, patient should use this combination inhaled corticosteroids plus formoterol. Nevertheless, relation to the symptoms. For example, at morning, at night, you use low dosage inhaled corticosteroids plus formoterol. And if patient have got a symptom exacerbation during day, during night, he also use this combination for purposes of reliever medication. But so, if we reach control to the according to step 3, for example, in 1 month patient come to your office for the next visit and answer for question, and you make conclusion about well asthma is well controlled, patient should remain for on this step during 2 months, because only after 3 months you should make conclusion about step down, and patient can transfer to the step 1, 2. Other things, if patient have got a good adherence to treatment, have good inhalation techniques, correct use inhalation devices, but patient didn't reach to control, well control, you can make conclusion that patient should make step up and transfer for the step 3 to the step 4. Step 4 including medium dosage inhaled corticosteroids plus formoterol. And diagnosis, you can change this diagnosis, because this diagnosis will be asthma, severe bronchial asthma. And in case of step 5, you can add to medium dosage inhaled corticosteroids plus formoterol, long-acting anticholinergic drugs. It's tiotropium bromide. Tiotropium bromide. It's triple therapy. And for each step during symptoms during exacerbation, patient use as needed low dosage inhaled corticosteroids plus formoterol. In step 5, if patient didn't reach to well-controlled bronchial asthma, patient can use according, we should detect the clinical phenotype and endotopic bronchial asthma. In the case of T2 phenotype, you can recommend patient a monoclonal antibody against IgE. It's omalizumab. Monoclonal antibody against interleukin-5 and receptor for interleukin-5, which interleukin-5 is cytokines which provide infiltration of eosinophils in the locus morbi, in site of inflammation. It's such drug like dupil, it's restylizumab and mepolizumab. Or you can recommend patient monoclonal antibody against interleukin 4, interleukin 16 is dupilumab. It's other things. Patient you should consider about high dosage inhaled corticosteroids plus formoterol. But this other approach to treatment, if patient have good compliance with physician and patient can use a lower dosage inhaled corticosteroids. And the step 1, step 2. In step 1, inhaled corticosteroids whenever patient use short-acting beta agonist. In case of step 2, low dosage inhaled corticosteroids is constantly for control medication. But in this case, patient can use short-acting beta agonist salbutamol, for example, as a reliever medication. Then step 3, low dosage inhaled corticosteroids plus long-acting beta agonism. Step 4, a medium dosage plus LABA. And step 5, medium or high dosage inhaled corticosteroids plus long-acting anticholinergic drug, tiotropium bromide, and also monoclonal antibody. But so, assessment of the asthma control, including 4 questions. You should ask patient during next visit after start of therapy and during therapy. First time, daytime asthma symptoms more than twice a week. If patient say yes, it's 1 point, no, 0 point. Any night awakening due to asthma? Yes, 1 point, no, 0 point. And third question concerning first 2 question, relieving needed for symptoms more than twice a week. Yes, 1 point, no, 0 point. Any activity limitation? Yes, 1 point, no, 0 point. So what does it mean, asthma well controlled? If a patient asked no for all 4 questions. If patient have got 2 positive answer for this question, for example, first and third, it's partial control. If patient ask positive answer for 3 or 4 questions, it's uncontrolled bronchial asthma. That's why patient have got mild asthma, for example, patient treated according step 4, step 4, it's mild asthma, but asthma uncontrolled. That's why diagnosis mild uncontrolled asthma. Other things, patient have got severe asthma, but patient have no symptoms. But patient treated according step 5, high doses inhaled corticosteroids plus LABA plus LAMA. He reached control, but patient have got a bronchial asthma, severe course, well controlled. But if patient this control remains at least 3 months, you can make step down. For example, diminish of the concentration of inhaled corticosteroids from the higher dosage to medium dosage. Okay, in this slide you can see the inhaled corticosteroids, which made revolution to treatment bronchial asthma and prognosis. Previously, approximately 80% patient with therapeutic pulmonary department were patient with exacerbation of bronchial asthma. But now, due to providing inhaled corticosteroids, it's only 1 or 2% among patients with therapeutic pulmonary department with exacerbation of bronchial asthma. Medium dosage and high dosage. You should emphasize that you can prescribe inhaled corticosteroids for all steps of bronchial asthma, and you can treat asthma with only with inhaled corticosteroids. It's true, because it's main control medication which have great impact to chronic inflammation in case of bronchial asthma. But much better if inhaled corticosteroids combined with long-active beta agonism, because if patient inhale corticosteroids, it's not immediately response for patient. It's necessary to time that inhaled corticosteroids reduce airway inflammation. But long-acting beta agonism provide bronchodilation of the bronchi. That's why this combination is a preferable combination. Start with step 3, combination inhaled corticosteroids plus LABA. For example, Seretid, Evohaler, Seretid discus. When fluticasone propionate, it's inhaled corticosteroids. Dosage difference between your purposes in Evohaler and discus, and salmeterol, long-acting beta agonist in discus. And this way, but you should know that salmeterol duration of action 12 hours. That's why these devices, Seretid, should be prescribed 2 times per day, BID. Other things, for example, if we use fluticasone, vilanterol, duration of action 24 hours. That's why this combination, it's a trade name Relval Ellipta, fluticasone plus vilanterol. You can prescribe 1 times per day, QID. It's so. We talked about that inhaled corticosteroids plus formoterol can be used for reliever and control medication, because formoterol it's very rapidly onset, 1 minute, and that's why it's a so-called smart therapy. Symbicort maintains and reliever therapy. That's why in one devices you can use at night, at morning for control medication, and during bronchial asthma attack, during asthma symptoms, patient can use these devices as a reliever medication. But Mars therapy, it maintains and reliever therapy of bronchial asthma. But long-acting anticholinergic drugs is tiotropium bromide, Spiriva in handy color, 80 milligrams, and Respimat 2.5 micrograms. Short-acting beta agonist salbutamol, for example, and phenaterol, but this short-acting beta agonism, now monotherapy for these drugs is prohibited. In case of severe bronchial asthma exacerbation, you can use this SABA, short-acting beta agonism, as a nebulizer therapy. It's mesh nebulizer. It's a new form of nebulizer, and nebules of Ventolin salbutamol. So GINA is no longer recommended treating adolescents with asthma with short-acting bronchodilators alone. Also, background of changes in GINA 2019, the risk of mild asthma. 1/3 patient with a mild, so-called mild asthma have got a exacerbation. Among these patients, 60% have got a near-fatal asthma exacerbation, and 20% dying from the asthma exacerbation. That because mild asthma often, if the symptom of asthma trouble in patient, no significant trouble or patient maybe adherence to treatment significantly diminished, and patient forgotten use daily usage inhaled corticosteroids treat asthma correctly, but under the influence of viruses, pollen pollution, it's lead to severe and sometimes near fatal asthma exacerbation, and so this patient deaths from the asthma. That's why you should know about it. But in frequent use of short-acting beta agonists is associated with beta receptor downregulation, decrease of bronchoprotection, and rebound hyperresponsiveness of bronchi. And it also associated with adverse clinical outcomes, with, for example, dispensing of more than 3 canisters per year, the high risk of emergency department admission, and associated high risk of death. Also, in patient of bronchial asthma, you should assessment of risk factor for poor asthma outcomes. It's such risk factor for high risk of poor asthma outcomes. If patient was intubated for asthma, uncontrolled asthma symptoms, patient have got more than one exacerbation in the last 12 months, a low level of forced expiratory volume, incorrect inhaler technique, obesity, pregnancy, blood eosinophilia, risk factor for fixed outflow limitation, no treatment with inhaled corticosteroid, smoking, occupational exposure, mucus hypersecretion, blood eosinophilia, and risk factor for side effect, and significant side effect in it's frequent of oral steroid, high dosage inhaled corticosteroids increase risk for example, pneumonia, and also use liver enzymes P cytochromes P415 inhibitors. Few words about COPD. I told that main symptoms for COPD, dyspnea and cough, and sputum production. And risk factor of COPD, tobacco smoking, and other environmental exposure, such as biomass fuel exposure, air pollution, contributes the development of COPD. You should know the previous course, at least there are two COPD phenotypes, pink puffer and blue blotter. Pink puffer is for emphysemic phenotypes, blue blotter chronic, mostly chronic bronchitis. And now we have other phenotypes like a combination overlap asthma, COPD. COPD with high systemic inflammation, COPD in female, in young patient, COPD with rapid progression and frequent exacerbation. In this slide, you can see the CT scan with to the left side, it's emphysema phenotypes. You can see the formation of emphysema. And to the right side of the slide, it's bronchitis phenotypes. And patient with symptoms, shortness of breath, chronic cough, and sputum plus risk factor should be direct to spirometry investigation. We often should evaluate clinically, for example, dyspnea, progressive over time, characteristically was with exercise, persistent. Chronic cough may be intermittent and may be unproductive. Sometimes you can detect recurrent with chronic sputum production. Any pattern on chronic sputum production may indicate COPD. It may be mucus, mucopurulent, and history of factor. I told about tobacco smoking and PAC, yes, and cigarette index, smoke from the home cooking, occupational dust, and family history of COPD and other childhood factor. For example, low birth weight, childhood respiratory infection, and other. When we direct patient to spirometry investigation, first after this investigation, we should pay great attention to this ratio after bronchodilators test, and this ratio should be less, in case of COPD, should be less than 0.7 or 70%. Other things, when we analyze spirography investigation, we should evaluate severity of airflow limitation. And there are 4 grades of airflow limitation: mild, moderate, severe, and very severe. Termed by GOLD 1, GOLD 2, GOLD 3, and GOLD 4. GOLD 1, it's mild, when FEV1 more than 50% from predictable level. GOLD 2, moderate, from 50 to 80% FEV1 from predictable level. GOLD 3, from 30 to 50. And GOLD 4, very severe, less than 60% from predictable level. By the way, I would like to stress, if patient have got GOLD 3 or GOLD 4, you should not wait that after your treatment, this airflow limitation, severity of airflow limitation significantly improved at all. Because I repeat once more, in case of COPD, we deal with persistent airflow limitation. If GOLD 3 after your treatment, including firstly bronchodilators, improved and become mild, you should change the diagnosis for bronchial asthma because it's confirmed about variable type of bronchial obstruction. That's why the GOLD 1, GOLD 2, GOLD 3 previously will be combined with clinical groups, but now it's separated because it's not target for our treatment. We only make conclusion. Patients have got, for example, GOLD 2 or GOLD 3. All patients should be filling this at least two forms questionnaire. It's a so-called CAT test, COPD assessment test, and MMRC, a Modified Medical Research Council questionnaire concerning dyspnea. For example, in this slide, you can see so-called CAT test, COPD assessment test, which included several questions. For example, I never cough, it's 0 point, and I cough all the time, 5 point. Other question, I have no phlegm, mucus in my chest, 0 point. My chest is completely filled of phlegm, and 5 point. Patient answer for this question. If a total score more than 10 point, it means more symptoms, more influence, more impact COPD to the healthy status of patient. And dyspnea scale, including grade 1, grade 0, 1, 2, 3, 4. If a patient with COPD have got grade 1, 0, it's less dyspnea. If patient have got 2, 3, 4, it's more dyspnea. For example, what does it mean? Grade 4, 2 breathlessness to leave the house, or breathlessness when dressing or undressing, very severe dyspnea. That's why it's help you to distinguish clinical groups. This classification of COPD, first experimentally confirming, and you told is clinical evaluation of symptoms because it's chronic process, this chronic dyspnea, chronic cough, and post the main spirometry criteria, post bronchodilators ratio FEV1 FEVC less than 0.7. By the way, you can ask me because COPD is a problem not only in airways. This problem is parenchyma. You should wait diminish of FVC because FVC also reflected to restrictive disorder, but due to bronchial obstruction, airflow limitation, we detect more significant diminish of FEV1. That's why its ratio diminished less than 0.7. That's why it's crucial for diagnosis. Without this criteria, we can't right to make diagnosis COPD. Then we detect GOLD 1, GOLD 3, GOLD 4, and in the central part of classification, exacerbation history. And patient can be divided into two categories. Patient with frequent exacerbation and patient with rare exacerbation. With patient with frequent, one and more leading exacerbation to leading to hospital admission, or two outpatient hospital exacerbation. It's patient frequent with frequent exacerbation, clinical group C and D. Frequent patient with rare exacerbation. It's 0 and 1, not leading to hospital admission, group A and B. Why the exacerbation now in the central part of the classification? Because exacerbation really worsening prognosis patient with COPD. Exacerbation really reduce lifespan of patient with COPD. Exacerbation provide development of complication of COPD, for example, chronic lung failure, pulmonary hypertension, and others. That's why now we should distinguish group A from group B, because all of this and group C from group D, because all these patients A and B and C and D have the same exacerbation. For distinguish this in groups, help you to this questionnaire MMRC or CAT. If CAT less than 10, MMRC is 0.1, it's group A and C. If a patient have got more symptoms, more impact, it's MMRC more than 2, CAT more than 10, a group B and D. So what kind of treatment should we provide for treatment patient with COPD? First, how can we fight against frequent exacerbation? Firstly, and first place is stop smoking, smoking cessation. It's obligatory and requirement for treatment patient with COPD. If patient can't stop smoking, you should help patient with pharmacological support. And secondly, because exacerbation happened due to under the influence of viruses, exacerbation or bacteria, it's a very important vaccination. For example, influenza vaccination, each year's annual vaccination. Now, it's very important in vaccination against coronavirus. Now, it's very important vaccination against coronavirus, and also a pneumococcal vaccination and pneumococcal conjugated vaccines. So a patient should start with pneumococcus PCV13 vaccine, and it's conjugation vaccine against 13 variant of pneumococcus. And in 1 year, patient can use with COPD. Patient with COPD can use revaccination by pneumococcus polysaccharide vaccines against 23 variant of pneumococcus. It's recommended for patient with COPD because it's significantly reduce the number of exacerbation and exacerbation complicated by pneumonia. Okay, come back to the previous slide. How can we treat patient with COPD and clinical groups? So if patient has less symptom, group A and C, we should start with long-acting bronchodilators. You can prescribe for group C and group A long-acting bronchodilators, LAMA or LABA, long-acting beta agonist or long anti-cholinergic drugs. Group B and group D, we should start with a combination of LABA plus LAMA, because more symptoms, more dyspnea. The combination is preferable for treatment this patient. Group D, if the patient have no good response to this dual bronchodilator therapy, if patient have got more than 300 eosinophils in 1 milliliter of the peripheral blood, we should think about triple therapy, including inhaled corticosteroids. That's why LABA plus LAMA plus inhaled corticosteroids. But I would like to stress that for patients with COPD, inhaled corticosteroids is not a first choice of drug. Inhaled corticosteroids is last choice for added to this dual bronchodilator therapy, LABA plus LAMA plus inhaled corticosteroids. But if patients who have got a good response to corticosteroids, we should stop corticosteroids and start LABA plus LAMA therapy. Other things is patient former smoker and patients have got diminished FEV1 less than 50%, goal 3, goal 4. We can prescribe phosphodiesterase 4 inhibitor. It's roflumilast. Daxus, for example, 500 microgram BID. So in this slide, you can see combination of long-acting formoterol, cledium bromide, formoterol glycopyrronium, indacaterol glycopyrronium, vilanterol imiclidinium, and you should know the duration of action. For example, formoterol glycopyrronium, 12 hours. That's why you should prescribe 2 times per day BID for cover all day long. But vilanterol imiclidinium you can prescribe 1 time per day because duration 24 hours. It's very important things. Combination drugs, it's for example, tiotropium respimat, it's Spiriva, it's LAMA, Spiolta, Tiolta respimat, tiotropium bromide plus olodaterol, but it's LAMA plus LABA. It's a combination drug, preferable for treat patient with group B and D. And sometimes we can prescribe patient with group D antibiotics. It's mostly macrolides like clarithromycin, azithromycin, sometimes more than 1 month. Especially if patients have got a purulent sputum. But we have from the different source of the scientific literature that patient with COPD treated during by such antibiotic during 1 year with positive effects for exacerbation. So the main goal for treatment of stable COPD is reduce symptoms, improves exercise tolerance, improve health status, and reduce risk of disease progression, prevent and treat exacerbation, and reduce mortality. By the way, a patient with COPD who have got a chronic lung failure, it's confirming, for example, saturation of oxygen less or below 88% at rest, and partial pressure of oxygen less than 55 millimeter mercury. Patients should recommended long-term oxygen therapy. It's approximately 60 hours per daily, with using of concentrate of oxygen. Patient who have a giant bulls can be consulted with surgeon for purpose of bullectomy, and lung transplantation, also surgical invasion, which help patient with terminal grade of lung failure patient with COPD. The time lecture is over. Thank you for your attention. If you have any question, you can write down in chat and ask me during practical classes and next lecture. Thank you for attention. So, once more, excuse me for technical problems.